Welcome to part 2 of the patient experience, where we'll cover throughput.
Good morning, Dr. Brown, Renee.
Good morning.
Good morning.
Y'all ready to round?
We are.
Yes, let's go ahead and start with Ms. Williams this morning. She had EKG changes upon presentation and admission yesterday and was scheduled for a cardiac cath yesterday afternoon, but she was bumped.
Uh-oh. Do you hear that? Bumped. And you know what that means. Avoidable day. With better communication with the interdisciplinary team, this might have been avoided, and the patient might have moved along the continuum of care.
I talked to the cath lab this morning, and they will get the procedure done this morning. And if it's all clear, then she'll go home this afternoon.
Ms. Williams is on the cath schedule for 10:30 this morning. Her prep and her education regarding the procedure has been completed. The pre-op checklist has been started.
Well, great. We've assessed Ms. Williams, and she has no discharge planning needs, and we have assigned an avoidable day to the cardiac cath lab.
Okay, well, let's go see Ms. Williams.
Great.
Good morning, Ms. Williams. How are you feeling this morning?
I feel fine.
Good, good.
Ms. Williams, are you having any pain?
No.
Do you need repositioning in bed?
No.
Does this sound familiar to anyone? Having any pain? Need to be repositioned? Aren't those the first 2 P's of hourly rounding? Let's see where it goes from here.
Do you need assistance to the bathroom? Well, we're here to assist you.
No, thank you.
Ms. Williams, you do understand that you can have nothing by mouth until after your procedure. Your procedure is scheduled for 10:30 this morning. After we get the results, Dr. Brown will then decide if you're ready to go home.
Okay.
Is there anything else we can do for you today while we're in here with you?
No.
Okay.
Mrs. Evans' hemophoresis is slowly improving. I see from the evaluation form that you've arranged for a skilled nursing facility transfer. I definitely think that is the way to go. Once she gets there though, PT is definitely needs to happen and needs to be aggressive. I think she can transfer tomorrow.
Great. I see in the PT notes that she still requires assistance of 2 for transfers, and her husband can't care for her independently at home, so SNF is the best option. Since we already have a nursing home identified, is there a reason that she can't go today instead of tomorrow?
Yes, I'm looking at my notes. I'm seeing her potassium and sodium are still not where they need to be for me to feel comfortable with the transfer, so I'm going to give her a one-time potassium dose and increase her daily potassium to 40 ml equivalents twice daily. Once we get her labs back in the morning, I think she'll be good for the transfer.
Ms. Evans has been on telemetry for 3 days. She's had no arrhythmias. Can we discontinue her telemetry monitoring?
Sure.
Leaving patients on telemetry for an indefinite period costs the hospital money and keeps the equipment from being used by other patients. The daily interdisciplinary communication could keep this from happening. In fact, this communication should address the identification and assignment of avoidable days, the identification of patients having transfer DRGs, potential documentation opportunities, and utilization of services, like telemetry.
Okay, great. Well, we'll make sure that her labs get drawn in the morning, and you'll have the results when you round, and we'll schedule transportation by 9:30. You know, our goal is to have our discharges out by 11 o'clock, so.
Good. Well, let's go see Miss Evans.
Great.
Good morning, Miss Evans. How are you feeling this morning?
Oh, I'm feeling okay.
Are you feeling any pain?
Not much.
Are you comfortable?
Oh, I'm a little uncomfortable.
Can I reposition your pillow?
Yes, thank you, dear.
Can we help you to the bathroom while we're in here with you?
No, the CNA's already helped me to the bathroom.
Good, good. As you heard the doctor say, we're going to be giving you some potassium by mouth in the morning, and we'll be drawing labs in the morning as well. And depending on what those labs say, we'll try to get you to the nursing home in the morning. Okay?
Thank you.
Is there anything else we can help you with while we're in here?
No, ma'am, but I appreciate all that you've done for me.
Well, good. Okay, well, we'll come back and check on you in a little bit, okay?
Yes, ma'am.
All right.
Do the 5 P's of hourly rounding apply when rounding with physicians? You bet they do. Ms. Evans can feel quite confident in her care when she has the attention of her physician, case manager, and nurse. They're just getting started, but you're about to see a great example of the relationship between the case manager and concurrent coder, and the positive effect it can have on the patient experience. They collaborate to identify conditions that were present on admission. Watch.
Amy, after reviewing Mr. Jackson's chart, I noticed that Dr. Shepard documented respiratory distress, yet the patient's on the ventilator. Is there any special documentation you need from us to help with your coding?
Actually, Ken, there is. We need a more definitive diagnostic statement documenting the severity and intensity of service for this patient. I will put a query on the patient's chart asking the attending physician to clarify if respiratory failure was present on admission. Do you know of any other plans for the patient?
I know they're working on weaning the patient. They're having a difficult time with it right now. Usually after 10 days of successful weaning, Dr. Shepard likes to put a trach in the patient.
Okay, that's good to know. If we do progress to the point that the patient gets a trach, please let me know, as that will change the DRG. In fact, looking at my census list, I see that we have several patients who are falling into DRGs that are also transfer DRGs. Do you know where they are in their length of stay?
Yes, Ms. Smith in 242 is in a transfer DRG right now. Mr. Jones is in a transfer DRG as well, but he's exceeded his gross mean length of stay, or geometric length of stay, so it's not really applicable in that case.
Okay, good to know.
They collaborate to identify potential documentation opportunities and to identify patients who are under a transfer DRG that may affect payment. With interdisciplinary communication, you can get so much done. Now that we've covered input and throughput, there's just one more aspect of the patient experience to explore: output. That's the subject of the next video.